Another beautiful day here in Texas today. 77 degrees, sunny.
Well, we had a little cold snap, which I know I'll get some comments about what we call a
Yeah,
cold
it doesn't
snap here
get
in
cold in
Florida.
Florida.
We actually turned our heat on for the third time in 3 years, so it was in the high 40s, but it's supposed to warm up now today and this evening and so the rest of the week into the 70s. So not bad. Well, it's 8 o'clock by my clock here in Anna Maria Island, Florida. Rich, here in Eastern time zone. I guess it's 7 there would make sense, right?
7 in Texas, yeah, 5 on the West Coast. So either getting off work or you've already had dinner or somewhere in between. So let's get started.
Uh,
Talk about how you can do dental sleep medicine in your practice.
well, very well. Well, I know a lot of you have attended our webinars before. I'm Guy Yatros. I'm on the left of your screen there. You can turn on your webcam if you want to see live shots of us here. For whatever reason, Rich there is on the right side of your screen. And how long have we been doing this now, Rich?
Long time. I don't know,
Yeah,
together what? Close to 25 years now? 35
yeah,
years, something like that?
probably closer to 30. I think we've been doing it over 15 each. So we've been doing it a long time. We've done thousands of devices, and we hope to impart some of that knowledge to you all tonight. We want to thank NDX Labs, and we've been using them for about as long as we've been doing this. As National DENTEX Labs are one of the biggest labs out there, but you also get that local feel to them because they have local branches, and they do a lot of the devices. The majority of the devices that we do, they do them. And in particular, one of my favorite devices, and one that I wear most nights myself, is this Clear Dream, and it's just a great device. It's I would say one of the best values out there on the market because it's clinically unbreakable. It's made in that injection molded acrylic, so actually wax it up, and it can be made very thin, and it's extremely comfortable. So as most of you who might know me, I do wear a dental device every night, and this is the one I choose more nights than not, even though I probably have several dozen of them in my medicine cabinet here. And you should really, if you're new to this or been doing it a long time, you should really try the Clear Dream out. And it's made out of the same material, Rich, as these NTI pluses that are made. It's in that really strong injection molded acrylic. So you do any NTIs, Rich, these days?
We do some of those, and sometimes we incorporate that particular design even into that Clear Dream as well. So I don't know if we'll get to that tonight. That's probably a topic for a little more advanced
Bruxism.
course. But yeah, that stuff's good. I've got a couple of them as well, Guy, and I'm gonna take one out in the driveway and run over it with my truck and see if it'll actually break it. I'm not sure it will,
I
but
don't know that it will.
it is tough stuff, man.
Yeah, one of the other companies that one of our partners is a instrumentarium, the Cable Kerr Group. You can talk to Ed if you want to talk to him there, and I've really gotten involved in this at the last year and a half as I had a new partner in my practice. Rich and I are partners in the DS3 system, but I actually have a clinical partner that helps me see all the patients we have in our 3 offices, and she just insisted that we have a CVCT when she joined me a year and a half, well, I guess about 2 years now. And we went out and researched it, and I found that the instrumentarium, the OP300, is the one we put in. And through that relationship, we've really found that there's a great use for it in dental sleep, and I know a lot of you all use these in your practices. Rich, do you want to talk about our what we do
Yeah,
at Dental
we
Sleep
had
Solutions?
about 600 IQ points in the room that day, and it took us, half a day to come up with this. But, Guy and I started this several years ago, and we're the most trusted, innovative, customer-focused provider of solutions in dental sleep medicine, period. That's what we do. We help dentists implement this and succeed. And that's all we do. So you and I have been helping a lot of dentists, Guy. I think that's what makes us feel so good about what we do, is that we help a dentist who then goes and helps a patient, and we're doing that over and over again, and a lot more patients are treated now and living longer because of what we do.
And we could talk at the end a little bit about how we do that, but we call it our DS3 experience, and what we mean by that is we want you to experience success in dental sleep, and we help with all aspects of that, whether you're a novice and you need education and implementation systems, or whether you're doing this and want to know how to do it more efficiently. That's what we do at Dental Sleep Solutions. We also do a lot of education, and our big symposium's coming up. This is the first year we're doing this, and it's going to be an annual event. It's almost sold out. We have some of the leading lecturers and speakers on dental sleep throughout the country, from John Rimmers to Keith Thornton to Rich and myself, Aaron Elliott, as you can see there. And we're not even really pushing that too much tonight because we've got less than a dozen spots left. We're almost sold out for that coming up February 17th and 18th. So if you were thinking about coming, you better be getting a hold of us soon, because those last few spots will be taken up shortly. What Rich and I spend our weekends doing, besides fishing or being with our families, and as you can see, we do a lot more of this, is we spend our time educating dentists. And we have 2- and 1-day courses to help really, I can honestly say that I think we do the best job of saying, this is how you do this in your practice. Here's the tools you need. Here's the systems that you need. And if you're wanting to do one of these courses, we'll put them up again at the end. You can type in tonight course, and you receive $50 off a 1-day course and $200 off of a 2-day course. All you have to do is type that in, and someone will contact you tomorrow, and you can secure that discount, because the normal rates, I think, are around $9.95 for a 2-day and $3.95 for a 1-day. So it makes them quite reasonable, and our team can give you the details on that. So this is what we do. We help you with all the aspects. So we're going to get started helping. If you have questions, type them in the question box, and we'll get to those as we can. And we have everyone muted. If you have a verbal question you'd like to ask, we can certainly do that as well. You can click the little hand feature, and we'll get to it when it's an appropriate time, and we'll be happy to hang out afterwards. So, Rich, we've been using this slide for gosh, a long time, haven't we, with the radar?
Yeah, that's pretty cool. I mean, obviously it is on your radar because you're on the webinar with us tonight. We appreciate you spending some time with us. But, it's out there. I think, Guy, you and I scratch our heads sometimes, and Guy's got a little more hair than I do. But, why don't more dentists do this? And I think there's just a lot of misinformation out there. So let's get started with sharing some of that stuff about how people can get into doing this.
Yeah, and why, too? I mean, it is on your radar. I think it's growing. It's a big area in dental sleep. And one of the reasons is because nothing else you're going to do as a dentist has a more profound effect. I mean, we're literally extending, improving, and saving patients' lives. And you don't have to go very far to see it's not only on the radar of the dentist. Look here, the Judge Scalia. I think as we speak, we're maybe going to be getting an appointee for here as a him, or and this has been a big to-do, and the guy died in his sleep with his CPAP, which was, CPAP's highly effective with one caveat: you have to use it. It was unplugged beside him when they found him dead in his sleep. So this is a big deal. It's in the papers. We have now the Federal Motor Carrier Safety Administration is taking action to say that, look, if you're a commercial driver, interstate driver, and you are on the roads and you are at risk for having apnea, then you have to be tested. And they're mandating screenings for these drivers and testing for the drivers who are at risk. And one question, Rich, I ask, and I don't think I've even shared this with you, but hey, does that sound like a good idea to you? That hey, these drivers that may be falling asleep at the wheel, that we should screen and test them?
Yeah, well, if we made it mandatory, whatever you ordered on Amazon.com wouldn't get there in 2 days. I guarantee you that. So, we gotta do this, and I think as dentists, remember what 1 in 4 people are using CPAP, successfully, and that's 4 hours a night, 5 days a week. So, what we do is a viable treatment option. And until we get more dentists out there doing it, we're not going to get more market share. There are millions of people who have this disease, and as dentists, we're in a great position to do that. I mean, we've been saving teeth for a long time, Guy, and we should feel good about that. We take bad smiles and turn them into good smiles, and there's nothing wrong with that. We should feel good about that. But like you said earlier, there's nothing that you can do that will impact your patient's life more than treating their airway, and that's a good way to look at it.
And you know what? And one thing, it's been a long time since Rich has done restorative dentistry. It's not been near as long for me, and having a busy dental practice for many years, if I'd only known how the airway affects that, how it affects our restorative treatment plans, once you learn that link, you can really do both. I mean, you can save the patient's lives and you can improve their overall health and even their teeth and occlusion, because we can think about some of the reasons that they do these things. So we think you can do this and you should do this, and at least you should be screening. And one of the reasons I put that slide up about the transportation department is because, yeah, most people say it's a good idea. Sure, they should be screening for this. But we don't, at the same point, we should maybe be embarrassed as healthcare professionals that the Federal Carrier Motorist Administration, or whatever the initials stand for, they're mandating that the screen, and here the medical field is not. And the reason they're doing this is because we are failing as a medical, in the medical field of screening our patients, because 1 out of 10 people who have apnea know they have it. So it's something we need to be involved in, and there's really no better medical caregiver than dentists to be involved in this. I think you'll see at the end of this webinar. This practice parameters, Rich. Go ahead.
A lot of this started back in 2006, Guy. We talked about this as the day the earth shook in dental sleep medicine, and it basically came out and they looked at 400 or 500 studies and they said, oh, hey, you know what? You can use a dental device. Dental devices do work. In fact, for mild to moderate, you can even use them as a first line of therapy. So they have since come out with new practice parameters who can do that, and how they've changed that a little bit. So it's not exactly the same parameters now, but the idea that as a dentist, we can be screening our patients and helping them get sleep tested, and then we have a legitimate treatment option that treats the majority of patients successfully. I was a little bit embarrassed that the physicians had to come up with this on their own. That as dentists, we didn't proactively do this. And that's why Guy and I spend so much time doing these types of things and spend our weekends helping dentists understand the opportunity that's out there.
Yeah, and if you'll read this, I mean, dentists need to be involved in this. For patients who can't wear CPAP, the alternative is dental devices. And for people who have mild to moderate, they should be given a choice between the two. And, it doesn't say anything there about surgery or cutting uvulas out, by the way, or the other things people think are the options. Those are the two treatment options that are out there. And I see we're getting some questions. We will answer them as we go through. I like this video. I've got it off the internet years ago, and it shows someone having apnea. And the thing I think that's really important to think about is, as you watch this person struggling to breathe at night, realize that most people who have this problem don't know they have it. So this person's not going to wake up saying, oh my gosh, I choked last night. They may wake up with a headache. They may wake up with and live with heart problems and high blood pressure and a lot of things this cause, but they won't know that this is happening. And I want you to think about, as a dentist, if you could help this person understand they have this problem. I'm going to let them start playing here. And as they understand that they have this problem, and then help them treat this problem, what's a better day's work than doing that? So what is it we have here? It's obstructive sleep apnea. So he's breathing, or he quit there. He's not breathing. What's going on there? He's got a cork in his throat, right?
That or a big tongue.
Yeah, that's exactly. Well, that's what's corking it. Is he trying to breathe? Do you think his blood pressure might be going through the roof here? Do you think he may have a headache in the morning? And what's going to keep him from dying? Because he hasn't died the last 1,000 times I've watched this. I'm assuming he's not going to die tonight. But what happens here? So he did something there to keep from choking, and the whole thing starts over again. You want him driving your bus to, across the country or something, or across town even the next day. So that's what's going on. It's a simple problem. I mean, it's a physics problem here, right, Rich? It's just a collapsing. We don't have to get into detail on that, but you want to explain what's going on there?
So we're getting ready. We're all tired. We put in a good day of work. Those of us on the East Coast, we're getting ready for dinner on the West Coast, but we're getting ready to fall asleep. So when everything starts to relax, we fall asleep, and as we fall asleep, our airway naturally starts to narrow a little bit because there's a neural tone going on there. And on top of that, we've got this cage that is our skeleton that we inherited from mom and dad, and along with soft tissue that has to do that. So our airway starts to narrow. We start snoring a little bit. If it continues to collapse, we get to the point where we have an apnea, so it's actually closed down all the way and there's no air moving at all. We couldn't hear the audio on that guy. I was biting my tongue. I was thinking about doing the audio myself. That's what the guy kind of sounds like. But we get to that point where we're either trying to breathe and we're snoring real heavily and we're trying to get air into our lungs, and we become hypoxic. So our O2's dropping. At the same time, because we're using up oxygen in our body functions, even while we're sleeping, CO2 starts to build up. That's the hypercapnia part. And your brain at that point has to choose oxygen or sleep. And since I'm still here today, my brain chose oxygen last night. So I'm like, guy, I wear a dental device too for my mild sleep apnea. But it gives you a squirt of adrenaline. And that adrenaline is a smooth muscle contractor. Your airway is a smooth muscle that dilates when it contracts. So if you could have seen and if you could have heard that guy doing that, he's trying to breathe, but he's not getting any air in. And you start to see he gets kind of, aroused. He didn't actually wake up, but and then he gets that squirt of adrenaline, and then you get that couple of gasping breaths where your airway opens. He gets 2 or 3 breaths in, and then the whole thing starts all over again, and you get caught up in this vicious cycle that can happen. We've seen them hundreds of times per hour.
Hundreds of times. And basically the pressure from the air, outside atmospheric pressure, is greater than the air pushing outward from the inside and the muscles, and we get a collapse. I think you all get it. Now, my question is, and I love this slide that demonstrates why we should be involved in this, because when we do these live courses, we talk about, we know this thing's the tongue, and if we had cancer or something that might be suspicious of cancer or some sort of abnormality in the tongue, we would think that's in our wheelhouse as dentists. We should be looking at the tongue, and should we be involved in this screening? Well, my question is, should we be involved in this? What medical professional is in charge of finding the patients who do that? Is it the general practitioner? Is it the dermatologist? I mean, who is it here? I mean, I'll play it again because I think there's no sound that goes with this one, which is good. But I think it emphasizes that this happens at night. Oh, went the wrong way. Sorry. This happens at night, and as our patients fall asleep, their airway closes off. And the answer is, who's in charge of this is, well, 9 out of 10 people don't know they're having this, so no one's doing a real great job. The Department of Transportation is trying to step in and help us out. But other than that, we're not doing a great job of this, and we need to improve it. And the bottom line is, when that happens, according to the standard of care from the American Academy of Sleep Medicine and the American Academy of Dental Sleep Medicine, because now they have joint recommendations, there's 2 choices. You all know the first one. Most everyone who gets diagnosed with apnea has that one. What do you think most people say is the second choice, Rich? Do you hear something different than probably what's true?
Yeah, I think a lot of times people think surgery.
Right.
Yeah, and I don't know about you, but man, I'd sure put that on the back burner. But we as dentists, we got to stand up and say, hey, our dental devices work. One of the questions we have here, Guy, which I've been typing an answer to. Can you hear me typing, by the way?
Nope, can't hear you typing. No problem.
That's because I type pretty fast. So, but I'm answering that right now. But we just got to get out there and do it.
Yeah, and the standard of care. So one of the questions that came in is, do these work? And the answer is yes, they do. And we're going to show you at least one study on that coming up. And the standard is that mild to moderate apnea dental devices and CPAP are recommended. More severe, maybe more CPAP. But anybody who can't wear CPAP, a dental device is the next step. So these are the two standard of care treatments, and that's based on the fact that they both work. And we'll talk about how how they work differently in different ways, but they both do work. There are other treatments, but those are not first line of treatments for the most part, other than positional. I mean, the surgery isn't. Positional therapy and weight loss are more adjunctive treatments typically than first line of singular treatments here. So two treatments, and dentists own one of them, and the problem is most dentists don't know what procedures they need to do. A lot of the questions that were in the one question, Rich, you know, he said a mouthful. I mean, there's a lot of challenges that go along with doing dental sleep, and we've got to help your offices get to where you can effectively deliver these devices, because they do work if done correctly, and they're needed every day in your practices. Patients need these, and dental devices are an effective treatment as well as CPAP is an effective treatment. They both have their pros and cons, and as we go a little further today, we'll talk about where the CPAP shines and where dental devices shine. The CPAP works through continuous positive air pressure. Do you ever have anybody call anything besides a CPAP, Rich?
This is G-rated webinar, but we do hear occasionally people say that CPAP, you know, or something like
CPAP, and a lot of people don't even. Do you think most of your patients even really understand what this is doing?
No,
I don't think they
do.
do.
I don't think most of our patients understand anything about life. Myself, some days, but you know, it works if you strap that mask on tight enough and you turn that air up high enough. You know, you're going to blow the airway open. I use that analogy of those long, skinny balloons that you make animals out of. When you blow air in that balloon, it gets bigger. And when you quit blowing air in, it closes down. And that's exactly what's happening to your airway. But you got to remember, if you have a nasal mask on and you open your mouth, you know, that air's coming out somewhere. So it's an effective therapy, but it's difficult to use on a nightly basis for multiple reasons.
For multiple reasons, but it does work most of the time, not always, but it usually it's positive air pressure, so it blows the airway open. And you know, these are somewhat our opinion, but we know that a lot of people have apnea, and we know that most statistics show that somewhere between 8 to 9 out of 10 of them, so 85–90% of the patients who have apnea don't even know they have it. And furthermore, those who have it aren't treating it. So it's somewhere in the neighborhood of 2 to 3, maybe 5% of the people who have apnea are actually successfully treating it every night. And from a marketing standpoint, when the numbers are as much as 1 out of 5 adults has this problem, there's a huge opportunity here. Sleep apnea, in my opinion, is the most undiagnosed, untreated, serious medical disorder in our country. And $4 billion a year or more spent on CPAP. And a lot of times these CPAPs, even we just said they work most of the time, there's a problem with CPAP. It has to be worn. And, you know, the judge's CPAP was 0% effective the night that he unfortunately passed away, because he wasn't wearing it. So no matter how well it would have worked had he put it on, if it's not wearing it, the overall effectiveness of that treatment is 0 for that night. And, you know, I think we don't have to explain too much about why this is difficult. I mean, patients have this thing on their nose. It's hooked to a pump. The pump blows the airway open, just like Rich said, like blowing that balloon. You're kind of tethered. And these are some older pictures. They're cooler, neater masks. I mean, we've come a long way from this thing, right? Can you imagine? You ever try that one on, Rich?
I haven't tried that one on yet. That's pretty sexy, though.
We've gotten a lot better, and this was a patient I took a picture of in my office years and years ago when I was doing a lecture, probably a dozen years ago now. And, you know, you can tell it's an old CPAP, but look how stressed she is just putting it on, not even tied to her machine. So the bottom line is it stresses some people, and we can try to make this as appealing as possible. I found, actually, I think Jason, who works with us, found this on the internet. I mean, this was a real ad. Look at this. Some graphic designer sat down and said, we'll get this young couple and we'll make the, and by the way, he wears his glasses to bed. It was a real ad we found. And here's another one. I mean, this is as good as it gets. This is someone spending money to try to market to get you to purchase their product. And the fun thing about dental sleep is if someone knows they have apnea, they know they have an airway problem, and they can say, look, I can do one of these two things, which one are they going to choose? And it makes us as dentists, it's kind of fun because a lot of times the patients don't want the crowns that we think they need. They don't want the orthodontics. They don't want the things that maybe are in their best health. But here, if someone actually knows they have apnea, they often will choose our treatment. I can tell you, I don't wear this thing. Rich and I both talked about, we both wear dental devices, and you can tell how long we've been doing this because I look a whole lot younger in that picture. This study is kind of pointing to what we're talking about. When did this come out? Last year, a few years ago when they were, I thought there was a Frost and Sullivan. I think that's coming up next. I think what this is showing is, what does COAT stand for? It's
continuous open airway therapy. So one of the dental device manufacturers that put this together, and you look at the market share by countries, and here we are for dental devices in the United States, and we're at a measly 5%. And yet in some parts of the world, the dental devices have more market share than CPAP itself. I often wonder, Guy, if you and I hadn't been sitting around when we figured out what sleep apnea was, instead of trying to glue, a nasal pillows in somebody's mouth because we couldn't figure out, their nose, couldn't figure out how to get them to stay in. If we just said, hey, look at my little dental device here, I think we'd have more market share. But a big part of this, too, is not many dentists know about this, but Absolutely. That's why we want you out there doing this.
And this is a study I was talking about that came out last year, a little over a year ago, I guess, in 2015. Now it's been a year and a half or so it came out, I think. And this company, Frost & Sullivan, is a company that basically looks at market trends. And they have predicted from 2015 to 2020 a 5-fold increase in the oral appliance therapy market, so dental devices, in other words. And they're predicting it to grow to be over $500 million in the U.S. in sales by 2020. So it's due to this formula, and I think this answers goes towards answering one of the questions: do these things work? Well, let's define work. I mean, let's talk about the effectiveness of this treatment. Okay, well, that has to do with how well it opens up the airway. We'll call that the efficacy of the treatment. But the efficacy is affected by how much they wear the device. So the compliance is as important as the efficacy. So the overall treatment effectiveness equals the efficacy of the treatment times the compliance. So I think when you look at this on a CPAP, would you say 50% compliance is a reasonable thing to put? Let's say it opens up the airway 100%, which it always does. It doesn't always, but we're giving them that. With 50%, I don't think we're underestimating that.
You're a very generous man, and I'm going to remember that when my birthday comes around next year.
Yeah, well, I owe you for the fish and reels.
That's pretty generous.
Yeah, it is. I mean, so I don't think many people are going to argue that, saying that for someone to wear their CPAP every night, all night long, we're not talking about Medicare compliance, which is a little more than half the night. We're saying, hey, every night we want our airway open. Every night, all night long, most every night. 50% of the people that actually are given a CPAP do that. I think we're being pretty generous. So if that is true in this scenario, then we're having overall treatment effectiveness of 50%. Now, we'll show you some studies, and maybe a dental device doesn't work quite as predictably. Sometimes it works just as well. I've even had them work better. But overall, the efficacy is lower. So let's call it 70%, which is probably underestimating dental devices. But let's say you wear it all the time. Now you've got an overall treatment effectiveness of 70%. And you can play with these numbers all you want, but that's one of the reasons that dental devices are coming into more offices, why medical insurances are paying for them, and why this treatment is growing, because there's not a perfect solution yet. CPAP works great, most people, but they don't always wear it. Dental devices works well, not quite as well as CPAP in some cases, but most people wear it. And overall, if you look at the studies, and then we can talk about the 2015 parameters where they looked at the overall health of the patients, they seem to work pretty similar. And I think this is going to answer, Rich, the question of how well do these work. Is this the study you tell your patients most about, you think?
Yeah, I probably tell my referring doctors most about this, because, they're the ones that they don't want to refer to us. And that was part of the question we got was, hey, I have a patient who's a sleep tech or whatever, and they just don't believe these things work. What are you basing that on? Well, a dentist made one time and the patient came in for a sleep test and it didn't work. Well, did you titrate the device? Did you test them at 2 different positions? So Arnaud Hokema, who did this about a decade ago now, this was his doctoral thesis. And he had 100 patients, and he matched each one of these patients, the age, the BMI, the AHI, the LSAT. I mean, just
it was well
tit for tat. Yeah, just how you get 100 people like that, I don't know. And half of them got a dental device, and half of them got CPAP.
Right.
And what happened?
Well, if we look at, and you may not know what AHI, but it's the number of events an hour, and we look at overall treatment that dental devices were 77% effective versus 83% for CPAP. So CPAP was slightly more effective, but these are both effective treatments, I want to say. When you consider medicine, 77%, 80% is a good treatment result in most forms of medicine. For non-severe, though, look at the dental devices. They worked actually better than CPAP, 84 versus 80, and then the severe, the CPAP was 69 to 85. There's other ways of scoring that. You can, if you're looking at that, you can go back to the very back appendix, and they look at for what they call an AHI of 5, and even for that, dental devices worked better than CPAP for mild to moderate, not as well for severe, but overall they both worked. They both did a good job. They both seemed to help the patient's overall health. So for the question that we had, I would highly recommend that you get that book for around $20-something from the American Academy of Dental Sleep Medicine and take it with you to your meeting with those doctors. And you may also take these practice parameters. One of the things we have at Dental Sleep Solutions, we help our members with all these aspects of dentistry, and we have something called Snoozle, where all this information, all these webinars we've ever done, all the articles are all in a dedicated search engine, and you can, if you remember, you can just snoozle it and this information will come right up. I would take the newest practice parameters with me too, which are 50-something pages long, but you can print out the abbreviated version. And what it shows is that up to 83% of the people may not wear their CPAP, and that overall, what does it say? My thing's hiding it here, Rich, but the mean, I can shrink it here, the mean disease alleviation calculation, I think is what it says, with dental devices, it's comparable to CPAP. So, I mean, that's not Guy and Rich saying this. This is the American Academy of Sleep Medicine and American Academy of Dental Sleep Medicine agreeing to say this.
Yeah, and again, those practice parameters, that's what, Guy, I hadn't even seen this PowerPoint because you put it together. Thank you for doing that, by the way.
You're welcome.
And before this even came up, those were the 2 things that I mentioned in that answer was the Hokema study and then the 2015 practice parameters. And they compare directly about 10 or 11 different points. Which works better for snoring, a dental device or CPAP?
Right.
A dental device does, okay? So when you look at that stuff, it's really eye-opening, and especially for those doubting Thomases that are out there in the medical world that just don't have enough information. This is some really, really powerful stuff that you can take to them. Right. And you can also show this to your patients, just like you said, Guy. Hey, do these things work? I mean, when patients walk in my office, and I see a bunch of them, I made 5 dental devices just today, and they all ask the same 2 or 3 questions. Does it work? Does my insurance cover it? How much does it cost? So we have to, in that question that we had, what did it deal with? Exactly those things. Does it work? And how do we get paid as a dentist? And I think we have some more webinars coming up for some of that other stuff.
Yeah, we do. I think it's a good time to say it works if you do it correctly. You've got to have the right systems in place. You've got to be able to titrate, and that's not the purpose of this particular webinar. But we do dive into that in our courses and all of our other aspects of DS3. It's certainly if you don't have the knowledge as to how to titrate the devices, how to follow up, then that may be part of why we have that reputation out there. So, and it's not that difficult to do. You just got to put some things in place. For those of you who arrived a little bit late, if you've got questions, go ahead and type them in the question box. You can raise your hand, and at the end we'll unmute you and let you ask your question as well, and we'll stay around for any questions. Also, we have courses that we're doing all across the country, and you can type in course and you'll get a $50 discount on a one-day and $100 discount on a two-day course if you type that in, and someone will contact you tomorrow with no obligation, but at least you secure your discount on that. So, and we'll put those up at the end. So, love this slide. It's been a year since I've seen this movie, but I think the point there wasn't it? Which path are you going to go here? I don't remember which one it was. Do you, Rich, from the movie? But
yeah, Morpheus said, which pill do you want to take? You want to take the red pill and you go back to life as you knew it, or you take the blue pill? And we want you to not go back and just do dentistry anymore. We want you to get into doing dental sleep medicine. We want to help you do it. We want to answer those questions. There's a lot of moving parts, and it just takes a little bit of effort. But, I love this slide too, Guy. Why do we treat this? What is the big deal about this? Well, people die. It's just that simple. They're more likely to have heart attacks, myocardial infarctions, congestive heart failure, high blood pressure, strokes. We know that people who have sleep apnea are sleepy. We talked about the Federal Motor Carrier Safety Administration, where you have these people with the CDLs, the commercial driver's licenses, and we're going to be a big part of the answer to that, because people just can't wear CPAP, and they want to keep their job. If I got to keep my job, and then if I got to treat my sleep apnea to do that. We talk about GERD, diabetes, obesity, auto accidents, impotence, all of this kind of stuff. But these are multiple medical, very good reasons to treat this disease.
And to be clear, these are independently associated with untreated sleep apnea. So I know a lot of other things cause these problems, but sleep apnea untreated directly can lead to everything on the screen. And I think, I think I've mentioned this, you've heard me say this a bunch. Pete Dawson years ago told me, he said, Guy, if you keep in mind, every reasonable person wants a healthy mouth. No one wants periodontal disease and malocclusion and abscesses. You just, they want to be, they like to have a healthy mouth. Well, I think that's even more obvious with this. No reasonable person would want any of these things. And if you can wear a mouth guard, a mandibular advancement device, or even a CPAP to help prevent these, most people, I think, would at least give that a try, as opposed to thinking they're going to have those things in their life. The problem's huge, isn't it, Rich? I mean, and it's getting bigger every day. The numbers are pretty staggering.
Yeah. Unfortunately, we'll have time to go through the obesity slide series, Guy, but we're getting fatter as a country, and that is contributing to our sleep disordered breathing. But 30 to 40 million of us out there have this problem. And remember, only 1 in 10 has been diagnosed. So 9 out of 10 people out there that have this problem don't know it. So it's affecting a lot of people. As I think about the hygienist I had in my practice, Guy, back when I was doing fillings and crowns. By the way, the last crown I did for $385, I think. So that tells you how long ago I did a crown.
That's what they were going for in 1925, huh?
Yeah, exactly. But I had 2 of the best hygienists in the world, and they were just wonderful human beings, and patients loved them. And they'd come in, and the first thing they would say, "Why are you staying healthy? You haven't been in the hospital? Are you taking any new medications?" "Oh yeah, my doctor sent me to the cardiologist, and I have AFib now." I mean, that's a big red flag, when we talk about these patients coming in. Half of the people who have AFib have a sleep disordered breathing problem. So, there are different ways of looking at this, and we just have to understand as dentists, these people are walking through our doors every single day, and we just have to start identifying them.
Right, and we have systems to quickly identify these patients. Again, that's not the purpose of tonight. The purpose of tonight is to make you understand why you need to be involved in this. You can do this. You should be doing this. And look at the numbers here. Half the AFib, the hypertensive patients. The numbers are staggering. And here's why it's important. And I use this study now. I think Erin Elliott told me how she used it with her patients, and I think, wow, that's a great idea. So I print this study out. The next slide I'm going to show you, I print out, and I talk to the patients about, look, you have apnea, and all apnea is not created equal. The more severe the apnea, the bigger health risk you are. You're putting yourself at. And they did this 1,000 state employees back in Wisconsin 20+ years ago that volunteered for this. So they're working age people, and they've done 3 follow-up sleep tests on these patients. And the first question before they do the follow-up sleep test is, are you still alive? And what they found is after 20-something years, the patients up here who don't have apnea, so that's what that AHI of 5 is, most of them are still alive. I mean, I'm estimating where that line is. I have to move my thing over here to see it.
95%. Only 5% have died.
Right. And the milder apnea patients, well, it's a little bit lower, but it's not way lower, 4% or so, maybe 91%. The moderate apnea, 84% are still alive. But look at this, we're pushing 50%. 43% of the severe patients 20 years later are dead. And I mean, that is an exclamation point of why this is important. And the other thing is, dental devices work really well for mild to moderate. They get you back up here near normal. And for severe apnea, to go back to the question, we get people from severe apnea most of the time to mild to moderate. So does that worth putting a piece of acrylic in your mouth every night to make that change? And then maybe 1 out of 4 we get it all the way up to more below mild even. So if that doesn't emphasize, and it's 1,000 people in that study, Rich. I mean, it wasn't a small study and they're still ongoing with it.
It's been going on for a couple of decades. I mean, that's pretty powerful. And when we look at that slide, I like that slide too, Guy, and I use that with every single patient. And I just say, look, if I just get you from this line up to this line, I probably added 10 years to your life.
Yep.
I mean, that's a good way to look at it.
We print these out and hand them to all the patients these days.
Yes.
Why do this? I can honestly say, being a dentist now, pushing 30 years, I think now, I don't even know if I can add that high, and I've done all kinds of dentistry, from pediatric to nursing homes. I had 9 nursing homes at one point in my life. I worked for pediatric dentists for years. I had worked as an associate. I had my own general practice for 21, almost 22 years, and nothing I have done in dentistry has given me more of the feeling that I'm doing the right thing, and it's more meaningful. It just, at the end of the day, you feel good about what you do for a living. I think that's what makes Rich and I happy to do this, because we feel like this is an extension of what we do for our patients. If we can get some of the people on listening tonight to go out and start doing this, then man, we've done something worthwhile, and we've helped the world be a better place.
Well said. So how do we know if people have this disease? Most commonly we get snoring, and people laugh about snoring, and snoring is still a big deal. There are studies now that show that just with snoring, we're starting to see changes in the epithelial lining of the cells in our heart, all of these types of things. So we see people that are snoring, they're tired, they're sleepy. And remember, snoring isn't just the guy who's doing the snoring. There's the bed partner too, who's not sleeping well because of that. I love that picture, Guy, there for daytime sleepiness. That shows a kid sleeping. Yeah. Maybe it's a kid, I don't know, but this does affect kids too. Then we've got blood pressure issues, other health-related issues, diabetes. It messes with our blood sugar. We become, it gets a little bit harder to control our blood sugar. When we're tired and we're sleepy, I don't know what you do, Guy, but you know what I do?
You sleep? What?
Eventually I do.
I'll just go out there on the limb. Go ahead.
I go look for, a bowl of ice cream or, a bowl of cereal.
Oh, yeah, absolutely.
Something makes me kind of we crave these high carbohydrate foods, you know, when we're tired, and we can't go to sleep, you know.
Yep.
But you look at, you know, a lot of this kind of stuff, and we have the contributing factors of obesity, large necks, you know, menopause. What in the world does menopause have to do with it? So men have twice the incidence of sleep apnea as women until menopause, and a year later, the women catch up with men. You know, we're starting to wonder now, a lot of this, the mentation and the dementia diseases, maybe they're related to my brain not getting enough oxygen. Doesn't that make sense, Guy? What happens to my heart if I don't get enough?
It makes all the sense. My mother-in-law went down last few years of her life pretty quick, and her oxygen went down about the same time due to emphysema, other respiratory problems. So I think that it does. And the good news is we have a quick way of doing this. We can help screen our patients through our DS3 system. In a matter of minutes, you can look at who's at high risk and who's not, at less time or equal time of what it might take you to do an oral cancer exam. And so we all need to be doing our part of it, very least screening our patients. And you know, here we can, I think we've, you know, beat it to death here, but this is serious stuff here, and everything on this screen no one wants, we'd like to not have, and it can certainly affect our lives. And sleep apnea is at the core of a lot of this. And we don't want to think that all roads lead to sleep apnea, but certainly a lot of them do. And the more you learn about it, the more you really believe that. We can look at our patients and screen them. And again, we have a whole webinar on just on screening and testing and how to make those systems in your practice. But just go back to your practice and start looking at your patient's anatomy. I mean, what causes those tongues there? The scalloping of that tongue. What's causing those lines? You know, they're the. I don't know.
I was typing an answer. Sorry, I wasn't paying attention to you.
No, that's all right. The teeth are causing that. You know, the indentations of 8 and 9. It looks like they're on the edge. And you know, why don't we all have scalloped tongues? Well, because our tongues aren't all pushing on our teeth. Now, it could be, you know, that you don't have teeth. I'm originally from Kentucky, so I got to throw that out there. But you know, assuming you have teeth, we don't all have scalloped teeth and scalloped tongues rather. And some of us who do might mean that our tongue is being crowded, or we have a forward posture of our tongue, and we already screen for headaches. And you know, I know clenching your teeth at night can cause headaches. I know stress can cause headaches. A lot of hormonal things can cause headache. But you think you were that guy in the video that unfortunately didn't hear the sound for it sounds like, but that was choking and oxygen dropping at night and suffocating multiple times a night. You betcha that can cause you to have headaches as well.
Yeah, and remember, you know, Guy, what I was taught in dental school was somebody had a headache, you make them a night guard.
Yeah.
You know, that's what you do. So sometimes people who get headaches need a night guard.
Absolutely.
Sometimes people who
or an
grind
NTI.
their teeth,
An NTI is even better in many cases.
yes, and sometimes people who grind their teeth need an NTI. But you see a guy like this, you better rule out sleep disordered breathing first. And if you can't see the PowerPoints right now, you're on your phone. This guy just ground his teeth down to nothing. And,
Yes.
and Guy, you mentioned something earlier where you said, expand on this a little bit, because I'm not sure everybody understood what you're saying. When you were talking about if you knew how the airway was affecting the dentistry you were doing, expound on that just a little.
Yeah, so my dental practice was a highly prosthetic-driven practice. We did big rehab cases, at least one a month of a complete upper and lower rehab, implants, crowns, you know, what have you. And so the biggest challenges I had over the years, I mean, other than patient challenges like everybody has, but and things not standing up over time, it wasn't decay, it was bruxism, and the restorative that we would put in the mouth would break. And you know, it occurred to me as I started looking at this, look at these teeth. They did this to their teeth. What makes me think the porcelain that NDX Lab's going to do is going to hold up any better? You know, it's going to break too. Wouldn't it make more sense if we understood better why they destroyed their own teeth? What in the world would some, you know, sane human just grind their own teeth off for what reason? And we don't have time to do a whole bruxism.
We could talk about that for 3 hours, couldn't we?
We certainly could. But what I can say is that Airway has something to do with many, many, many of the cases. And if you come to one of our other courses, we'll talk about how Airway is related to that. And then many times, and it's not just our opinion, people who have airway problems brush their teeth 3 times more than those who don't. And when you fix the airway problems, the bruxism is most often improved for those particular patients. There's other reasons for bruxing. That's not the only reason. But it is one of the major reasons. And if I look back, those are the people who won't wear their bite guards either. Because you put that bite guard in, and it might even make their airway worse. And they tell you, Doc, I don't care that I spent $30,000 on this restorative. I'm not wearing this bite guard because I can't sleep with it.
Yeah.
And you think,
I just don't feel good.
I just feel horrible the next day. I just wear it. And they can't tell you why, because they don't know they're choking at night. And so just put that thought in your mind. If I'd have known, so to answer your question, Rich, if I'd have known that some of the patients that I had the biggest challenges, if I'd have known what I know now, I would have realized before I ever got started that they were prone to the airway problems. We'd have tested them for airway problems. Most of them would have had apnea, and we would have addressed the apnea along with the restorative care, and we would have had a far better predictable treatments in the long run. And yeah, I didn't learn that till towards the end of my restorative career, and boy, I wish I'd have known it 20 years ago.
Can I add that you would have had a lot less stress?
Oh gosh, yes, I would have had a ton less stress. So speaking of stress, we got to get caught up here. We're got a little sidetracked. So you know, this is the bottom line here. 1 in 5 adults has at least mild apnea, but only 1 in 10 know they have it. I mean, it's 20% of the adult population in the United States, but most of the people who have it don't know they have the problem. And it's just huge. The numbers are huge. And the ones that do know they have it, if you look at this little sliver over here, those people are the successfully treated, because even the ones who know they have it aren't wearing their CPAP every night. No one's giving them a dental device. So the numbers are huge. We went through these numbers to ad nauseum. We don't have to go over those anymore. The problem is awareness. And it's awareness that this is a problem. It's awareness that they should be tested. It's awareness that there are other treatment alternatives other than CPAP. And I'll even mention, you mentioned AFib, Rich. My mom got diagnosed with AFib a few months ago, not even a few months, but about 5 weeks ago, and because she was in the hospital for some pneumonia. And I was at her primary care, and I said, well, she needs to be tested for apnea. And he says, why is that?
This is the cardiologist.
No, this is the primary care, who's you know, someone I've known for years, and I said, because half the people who have AFib have apnea. Now, to his credit, the cardiologist did at least appear to know that, but it's an awareness problem. And we can help educate the public. We can educate the dentists. We can educate the physicians. And the awareness is going up. There's no doubt about it. It's gone up far better than it was when we first started, but it's still way lacking. And hopefully this will help. And you as dentists have the best opportunity. More patients see their dentist each year than they see their physician. We have better relationships with them. We know our patients better. We know where they go to church. We know what kind of boat they have if you're in Florida. I mean, we just happen to know our patients more. We have more time to spend with them, and they see us more often. And you know, Rich, you came up with the slide years ago, and I swear I think it's one of the most ingenious, and it really hammers home what has been going on in the past and how we have an opportunity to change it. So I'll let you talk, as I'll put it up on her.
Yeah, so SDB is sleep disordered breathing, PSG is a PSG. So in the medical model, we suspect that somebody has a sleep apnea problem, and for over 3 decades now, we've been saying, hey guy, you need to go get a sleep study. Well, only half the people go. I'm not going to that sleep lab. They're not gonna hook up all those wires on me. They're not gonna videotape me. I don't know what I do when I sleep at night. So a lot of reasons, but only half of them go. We confirm a diagnosis in most of those patients. What's the next thing we do? Hey guy, you need a CPAP. Half of the people won't even go get the CPAP. And then how many people will wear it? Like you said, 50%. I think that's generous, you know. So when we look at that medical model, we say, hey, how's that working for you? There's 10 people that have a problem, and we're only we could double those numbers, some of them, and we're only treating 2 or 3 people out of 10. Okay, and then the dental model, we suspect a sleep disordered breathing problem because we're screening our patients now. We utilize a home sleep test instead of going to the lab. The patient gets to do it in their own home. It costs less money. We get almost all of them to do that. You know, which test would I have, Guy? The in-lab test or the home sleep test? Probably the one my insurance company paid for.
Right.
And what are most insurance companies paying for now? They're only paying for home sleep tests. You have to have a specific history of stroke or seizure or something like that to even go to the sleep lab. So we confirm a diagnosis of sleep disordered breathing in most of these patients, and we know that most of them will wear a dental device. So again, you know, even if we cut our numbers in half, we're still treating nearly half of the people in the dental model, and the medical model is only getting a couple of those people. So I think in the dental model, we're doing twice as good as they are in the medical model, even though we're not doing things the same way. So this is a powerful slide for you guys when you get out there. And you know, you're right, Guy. I mean, you know, you're bending over there drilling on a tooth, man. I mean, you know, your hair's falling out. Oh, you're drilling, you know. Mine are already falling out, and that's what it's what your wife had to do to you at the end of the day, right? To straighten your back out.
Yeah, I mean, the point here is, you know, we not only have a model that can help patients, and we're not saying it's the only, the physicians still need to be doing their part, but dentistry's tough, and this can be a nice break during the day or during the week for dentistry, because dentistry's hard. It's physically difficult. I mean, the patients feel like this is what we're doing to them half the time, and with dental sleep, the stresses are far less. They're not missing, but they are far less. And I mean, I always said that for me to do a procedure in my office, it's got to do three things. I don't know if I learned this through the Pankey Institute where I've been or just figured it out on my own, but you know, if I'm going to do something, I want to enjoy it. Okay, dental sleep is great for that, and dentistry is great too. You might enjoy doing crowns and things that you do. Okay, I want to help patients. Dental sleep does that very well, more than general dentistry. And maybe it's because I'm a good person, and maybe it's because I'm insecure and I just need people to tell me thank you at the end of the day. I don't know, but I want patients to appreciate me for what I do. And then the last thing is you want to be able to make money doing this. And you know, there's nothing shameful about making money, and you can make money. That's all Rich and I do now. And this is back in a day in dentistry when I was in my dental practice. And you know, here's a busy day of Crown and Bridge with one hygienist in my kind of boutique practice that I had, and these black lines are my time. And you can see, even though we had a productive day of $6,000–7,000, not including hygiene, you know, I didn't have any time in my schedule. Here's $6,000 or $7,000 day in dental sleep, and look at all the blank white lines. And that's because auxiliaries can do the vast majority of this, and you can add this to your practice and really not even miss a beat and add a whole nother line of production to your practice. So that's the fun part about this. You can save lives, you can improve their lives, and there's nothing you can do in your practice to add more profitability. I mean, I think Rich, you and I are, I mean, we don't say that this is what everybody should do, but my sleep practice got so busy and profitable that I had to choose, and I chose to go down that path. And last year, you know, had the best year I've had in my life, and just doing sleep. So I'm not saying that's what you need to do, but you can certainly be profitable doing it.
Yeah, so we're fishermen here, and we love that slide. You know, are you hooked yet? So we want you to be hooked. There are a lot of moving parts to this. It's you know, if you can learn how to do a root canal, I promise you, you can learn how to do dental sleep medicine.
It's much easier, but maybe there's a lot of parts, just like a root canal. You got to have a lot of instruments out, systems in place. But technically, if you can do a root canal, this is easy. If you don't have the right systems, and even one of those systems broken, one of the questions that came up were success rates, insurance, team training, interacting with physicians. Each of these systems need to be in place in order to make this an efficient, fun, and profitable part of your practice. And if we don't have those, and you don't have a plan, it's not going to be as much fun, and you're probably not going to enjoy doing it as much. And we want dentists to do this because we feel there's a need for it, and nothing is difficult here as long as you have a plan in place to do it. And that's pretty much what we do, right, Rich? I mean, these 4 pillars is this.
Yeah, we really do try to help dentists do this. I mean, the 4 pillars we talk about forever: screen, test, treat, and bill. Those are the big links of that chain that guy's talking about. And if you can have a great screening system and you identify all these people and then you go, hey, go get a sleep test and then I'll see you in 6 months and we'll clean your teeth again. That would be like seeing some big lesion on their tongue and going, hey, you should have that biopsy. I'll see you in 6 months. We wouldn't say that. So those are the moving parts. And again, I see some of you guys typing in course there. So the symposium that's coming up, that's what we do, is help people do this.
Yeah, and you can, even if you're going to do this in your practice, which is what most of you will do and we recommend. I tell you, when I did it in my dental practice, it was, we would have some dental sleep patients. I usually had my stressful big cases come in the morning, and then I did things in the afternoon like dental sleep patients. And boy, it sure was nice knowing that in the afternoon all I had was a few dental sleep patients to check here and there. I had my legs kicked up drinking coffee, and life was grand there. There has never, went too fast, been a better time to get involved in dental sleep. When Rich and I first started doing this, if I can get this thing to play, it was kind of cool. Now it's not. There it goes. There weren't courses. We'll show you our courses again in a minute and give you that discount if you just type course again. But there weren't courses that taught you how to do this. You could go to AASM and you could learn about apnea, but they didn't teach you which device to use, how to bill medical insurance, how you communicate with physicians, how you titrate the devices, how you get the patients tested, all that stuff. It was none of this. This was just a forest with mountains and the dental sleep path we had to forge. Now all that's in place. You can get with DS3, you can get a home sleep test with a click of a button. We have on-demand webinars that you can see at any moment you want. We have go-to-meetings that we set up with all of our DS3 members, where we hand-hold them and walk them through the systems. We have the in-person courses. We have insurance billing companies that we network with to do all the billing. Now all that's been torn down, and all you got to do is really hop on board, follow the track that's been laid down through a lot of effort, a lot of time that we've spent putting that system together. If you're interested in knowing what we do, we're not high-pressure people. Our company's not high pressure. We've got dozens of people working in our corporate office, and they can walk you through what we do. We'll give you a demonstration of what we do. You can even see some of our online educational material that you can watch for a few weeks, and you can have a free trial. And just to see if you're really interested in saying, I really want to go forward, I want to get this going in my practice, we can really show you how that is. And so just type in free trial or call us, email us, and we'll be happy to do that at any point in the future that you want. But we recommend you doing it sooner than later, because we know if you put things off, it doesn't happen. And then as far as our courses go, the symposium is about sold out, so I'm not even going to talk too much about that. We got some great speakers. We have less than a dozen spots there. If anybody's interested in coming to the symposium, then contact us sooner than later. You can register right online at dentalsleepsymposium.com. It's a day and a half here in Clearwater, Florida, in February, coming up in a few weeks, and some of the country's leading speakers. But for most of you, I think if you came to this course, you're probably thinking about getting involved in this, and this is the courses that we do, the 1- and 2-day courses. If you type in course, we'll give you $50 off. Someone will contact you to talk about which one you want to come to off a 1-day course, and $200 off of a 2-day. In a 2-day course, you get a dental device made for yourself. There's a fair amount of hands-on experience with that, and I mean, I think we do the best practical courses anywhere in the country. What do you have? Anything to add on that, Rich?
No, we do. We want to help you guys do whatever we can to get this going and doing it. So if I could, I'd reach right through that computer and kick you in the rear end and say, hey, get it going.
Well, very good. Lastly, this costs nothing. If anybody wants to sign up for our Dental Sleep Medicine Insider magazine, you go to actually dentalsleepinsider.com. And we put this out every other month. I usually do a video. Rich does articles. We have guest articles. And we get really, really good reviews from this. It's very practical. Challenges in your office. for dental sleep and solutions, and it just comes to your inbox digitally, formatted to your email. So no obligation there. We recommend that you sign up for that. So I think I'm going to leave that up as far as how you get a hold of us. And Rich, do we have other questions here? Because we
Yeah,
got
I'm
finished
working on
almost
it.
on time there.
Yeah, I'm working on a couple with success rates and stuff like that. So, part of our success with all of this stuff, we mentioned the HOCMA study and we mentioned the 2015 practice parameters. So there are multiple studies in there that show, and the HOCMA study was when you define success as reduce the AHI by half and get it below 10. For mild to moderate disease, we're looking at maybe 70, 80%. And for severe, we're looking at 50 to 60%, something like that. So I'm typing that answer out right now, but that's pretty good. We're not used to that in dentistry, guy. Medicine is a different beast, and that's really pretty good.
Yeah, so I think there's other questions. Thanks, y'all. You're welcome. I see some thanks. And if you, again, we don't normally offer those discounts on the course. So if you're even thinking about it, type in course. We'll have your name, and someone will talk to you about the ones that are available. So make sure you just type that in if you want to secure that $50 or $200 discount, 50 off the one day, 200 off the other. I see a few people have typed that in. Again, no obligation, but if you call us tomorrow and say you want the discount, they're not going to give it to you without your name being secured on the website tonight. So what other questions do we have? Did you answer this insurance question? Looks like you answered most of that, Rich. Again, success rate I think we've got most of them. I see a few more people said courses. Thank you. I think you'll enjoy our courses. I'm positive that you'll get a lot out of them. We have really high ratings on them. So, whether you use us or not, I mean, get involved in dental sleep. Come to our courses, come to the AASM, go to some of the continued webinars. We're going to be doing more of these webinars. I should mention that for NDX. I think we have one coming up next month as well. So I don't even remember what that one's on. Rich, do you off the top of your head? Okay, well, so stay tuned if you for those, and these are free. We hope that you've got a lot out. I see a few more courses coming through there. Again, we'll contact you tomorrow. Someone from our member support expert team. By the way, we have a team of dental sleep experts. That's all they do. I mean, they come to work every day, and their job is to help dentists do dental sleep. They answer live questions via GoToMeetings, via phone, via email, and they're there to support you. So the free trial, if you want access to them too, you can find out what all they can help you with, whether it's which device to use where, or should you be a Medicare provider or not. We have the answers for you there. So I don't know the answer to.
It's on the patient. It's on the patient workflow, Guy. February 28th. We're going to talk about the protocols for how you try to walk a patient through. What do you do first? Do you do the insurance first? Do you screen them? After you screen them, well, how do we help get them sleep tested? So we're going to talk about those protocols and that workflow.
And what date was it again? The 28th, you said?
28th of February.
All right, February 28th, same time. We usually do these at 8 Eastern, 7 Central, 5 over in the California area. So if you found this to be beneficial, it'll be more detailed about specific things you do in your practice. I know this was a high-level overview because it was intended for you to understand that you should be involved in this and why it's important. And I hope our passion and desire to help our patients and help you do this came through, and we will look forward to seeing you next time. I don't see any other questions other than I don't know about the CE. We'll let someone they'll have your contact and let you know about that. I'm not sure about that question. So any other ones come through, Rich, that
no,
I didn't see?
Again, I don't know that either, but we'll find out for you
Sure.
Cheryl, and we'll let you know. I believe that you do get CE for this.
Yeah.
But we'll make sure.
Yeah, we hope so, because we put a lot of effort into it. You all took your time, and everybody was very attentive. Thank you, and we hope to see you at a seminar that we're doing somewhere soon, or on the next webinar on February 28th. And thanks for taking some time out of your evening to listen. Again, I'm Guy Yatros.
I'm
And
Dr. Richard Gray. Thank you, guys.
Dental Sleep Solutions. Have a good night.